All right. So, starting today with our eye and ENT topics, these are not enough, definitely, because they keep changing. They keep changing, adding in more and more topics. So, I will try to cover a little bit here and there apart from these topics as well. Just as yesterday, we were able to cover around 20 topics overall. Okay, so today as well, we'll try to do the same, doing more apart from the 8 topics that we have for today, right? Let's start then. So, optic neuritis. Eye cases just always have a brief structure in your mind that there are certain questions which can never be missed. In eye, in ENT, all these domains, you can't miss on certain important questions. Before I go on with the scenario, I'll just tell you the overall structure of eye. So when a patient comes to you, can come to you with redness of the eye or pain in the eye. Painful red eye is mostly a red flag. You might need to send this patient immediately to the hospital. Painful red eye. I'm not talking about only red eye. So painful red eye can be a cause of something serious, can be due to something serious. So what can be the different causes of a painful red eye? It can be due to glaucoma, it can be due to optic neuritis, it can be due to some trauma to the eye, it can be due to iritis, uveitis, it can be due to herpes infection. So you need to take a very good history in all these eye cases in order to show the examiner or in order to be a safe patient, to show the examiner that you are ruling out sinister things, important things, serious things, emergency conditions, and at the same time, you are actually being a safe doctor as well. What are the important structures? If a patient is coming to you with pain, you ask all the pain questions. Where did it start? When did it start? Which eye? Is it continuously there? Is it increasing with the passage of time? Anything that makes it better? Anything that makes it worse? On a scale of 1 to 10, how would you scale it? 1 being the minimum and 10 being the maximum. The same Socrates questions which everyone knows. Once you're done with the pain history, you go on to ask about other symptoms. What other symptoms? Apart from pain, do you have any redness in the eye, any discharge from the eye, any watering from the eye? By any chance, did you have, see, there are certain things that can go inside the eye. It can be a foreign body, right? It can be some sort of trauma, external trauma, and it can be lenses. So try to remember in this way the things that can go into the eye. And then certain things that come out of the eye. What are those? It can be discharge. It can be just this thing, watery eyes. Okay, so you need to ask the history in a way that you do not forget. Once you've asked these, you go on to your red flags. When a patient has an eye pain, you always want to rule out if this patient has any shyness to light. If that is there, then look for rashes, look for any headaches at all, any blurring of vision. Blurring of vision is obviously, that's the function of the eye, that is something which should never ever be missed. So blurring of vision, if it is on looking in front, on looking on the sides, or is it all over blurry, if this patient has been diagnosed with any conditions in the past, or if this patient is using any types of medications. So you need to take a very, very good history. Once done with the history, you go on to your meftosa. You can usually get your clues in the meftosa as well. Let's suppose, for example, in this optic neuritis case, this patient can be having a family history, right? And what are other clues to look for optic neuritis? I'll tell you those. Up till now, I'm just telling you an overall structure. So when you go to meftosa, you may find out that this patient is using amitriptyline. In case of glaucoma, you may find out that this patient has a family history of something serious. So it is very, very important to take a good history in all eye cases. Rule out your red flags. Once you have done that, you go on to examination. In terms of examination, always remember to say, Linda or Miss XYZ, I want to have a look at your eye. First, I'll check your observations. I'll have a look at your eye. Externally, you are going to do the observation, and then you are going to have a look at the back of the eye with a fundoscope. So in these cases, they are not giving us a fundoscopy examination, so you only and only need to verbalize that. But if you will not verbalize, they will not give you the findings. That's the problem. If you will not verbalize, you will not get the findings. So what are you going to do? In this case, this lady who is coming to you with optic neuritis, this case, she'll be 30 years old. You just imagine this patient. Usually, these patients are very young, not old. Young patient, female, coming to you with red eye, painful red eye, less likely glaucoma, right? Less likely any sinister other sinister issue. You will be thinking about optic neuritis. It should come to your mind when the patient is around this age. So this optic neuritis can be due to many reasons. When you go in, you greet your patient, you take a complete history, as I just told you. You already have a suspicion that this patient might be having some issue. When you ask her that, is it for the first time? The patient will tell you, no, doctor, it has happened before as well. All right, whenever there is an episodic history, you can always think of optic neuritis. Think of optic neuritis. Once you've that in your mind, you go on to take a little bit history of ankylosing spondylitis or of multiple sclerosis. So ask her about any back pains, ask her about any issues sleeping at night due to the back issues or leg pains associated with that. Then ask your patient about any weakness in one part of the body, problems in initiating certain tasks, which can be there in multiple sclerosis. So ask her about any rashes or any other part of the body if she has any symptoms. Once you've asked that, you go on to you ask eyes, does she have an idea, any particular concerns and any expectations? You go on to your meftosa. In meftosa, you are going to take a complete meftosa. Have you been diagnosed with any medical conditions, any allergies, any medications, any family history? The patient might give you a family history of mother being diagnosed with multiple sclerosis. All right. That does not mean that this patient has multiple sclerosis. So please remember not to make this blunder. In the diagnosis part, you are not going to give multiple sclerosis as the diagnosis. That is happening with many of the candidates. So you go on, you do an examination for the eye, an external examination, internal examination with the fundoscope. Once you've done the examination, you come onto your management part. One of the doctors messaged me saying that if I can precisely say the management of all cases, yes, I'll definitely do. So in this case, when you come onto the management part, what management are you going to do? There's a mnemonic that I made for the sake of management to make it easy for everyone to say in the exam situation. What's the mnemonic? The mnemonic is Qasim RRR, CASIM RRR. So those of you who won't be able to write it just now, please do not unmute your mics. I'll repeat it in the end. C means condition. A means admission. S means senior. I means investigations. M is management. Triple R's. First R is red flags. Second R is review. And third R is reading materials. That is your leaflets. One of the doctors is unable to join. Please give me a moment. I'll just mute myself and see what's the problem. I'll get back to you. In the meantime, you guys can just have a look at this Qasim 3 hours. Hello, yes, I'm back. All right. So once you reach the management of this case, you're going to tell the patient you seem to be having a condition called optic neuritis. Do you have an idea what that is? No, doctor. So you're talking about the condition. You seem to be having a condition called optic neuritis. It's a condition of the eye where there can be some swelling at the back of the nerve of the eye. Okay, so just simple words, swelling in the nerve of your eye. Once you told her this, tell her that sometimes it can be associated with some other conditions like multiple sclerosis and some other conditions as well. So don't say, she might ask you that, doctor, she might be concerned. It's very natural for somebody to be concerned that is it multiple sclerosis? Well, I do not mean that you have multiple sclerosis, Jessica, but it can be associated with that. So I want to send you to the AS admission or referral. Okay, so I want to send you to the eye specialist and the nerve specialist, the ophthalmologist and the neurologist. In simple words, eye specialist and nerve specialist or the brain specialist right now. Can I go home, doctor, and then go back maybe in a couple of days? No, Jessica, it's very important for you to go to the doctor immediately. Immediate checkup by the eye physician is very important. Eye specialist is very important because any delay can lead to permanent loss of vision. So you need to be able to convince her ethically. You need to counsel her that it's very important for you to go to the hospital right now. Once done that, you've already talked about the referral and the seniors and now investigations. Once you go there, they'll do some further investigations to confirm, like what? Like some scans of the brain and maybe some scans of the eye as well, right? So, do you have any questions? Do you have any worries? Do you want to inform anyone at home? Give her the red flags. By any chance, if you have any further issues, please do come back to us. I mean, after discharge from the specialist, after coming back from the specialist, if you have any other issues, please do come back to us. If you feel that there is any worsening of symptoms, your vision is getting worse and worse. She never asks you about medication, but if she does, yes, you can tell her that the specialist will give you some steroids to correct your vision, to improve your vision. Will it be completely reversed? Well, I'm not sure at the moment to what extent a damage has already occurred. So once you go there, the specialist will be in a better position to answer this question, right? So put that on your senior. I would like to review you once you're back from the specialist, maybe in 1 to 2 weeks time. And in the meantime, if you have any problems, to come back to us earlier, and then you can give this patient some reading materials. Reading materials about what? About optic neuritis, because you are almost sure that this patient has optic neuritis, so you can give her some reading materials about it. This is about optic neuritis. When we go next, what do we have? We have glaucoma. All right. So glaucoma. This case, many candidates. Just a moment, please. Again, a question. So many candidates, they do struggle with the glaucoma question, with a case where the patient is coming to you with a painful red eye. It's a very, very easy one again. You are FY2 working in A&E, who the patient is Krishna, aged 50, came to the hospital with redness in the eye. This patient wouldn't be like the previous one. Just have a look here. This is a young patient and usually a female. It can be a male as well, but usually a female. And look here, it's a patient who is aged around 50 years. So 50 and above, usually painful red eye, do think of glaucoma. It can be thought of in an earlier age as well, but do think of glaucoma in a painful red eye when the patient is 50 and plus. So you are in the A&E, the patient is coming to you. You take the history as we've already discussed. Pain, when did it start? Is it for the first time? What type of pain is it? Does it go anywhere? gets better with anything, gets worse with anything, or your Socrates questions. Once done with that, ask the patient that why usually this patient might be wearing some sunglasses. May I know why you wearing the glasses? Doctor, the light is bothering me. All right, do you want me to dim the lights? Yes, doctor, you can get up and dim the lights. So, apart from the light, is there any issue? No, doctor. Have you had any rash or any fevers recently? So, you rule out your red flags first of all. That could it be meningitis? No, doctor, no rash and no fevers at all. Any flu like illness, cough? No, nothing like that, doctor. All right. Now you come to your glaucoma questions themselves. You've asked the pain history, you have ruled out your red flag, then you ask your patient that have you had any headaches, any nausea, any vomiting, any other symptoms at all? No, doctor. Then the other eye history, which we've already talked about, anything coming out and going in. Have you noticed any discharge, any watering from the eye? Have you noticed, by any chance, were you using any lenses in the eye, or by any chance, any eye trauma? Once you're done with the history, you go on to your meftosa. In the meftosa, have you been diagnosed with any medical conditions? Yes, because there can be certain medications which are related to glaucoma, which can be a risk factor for glaucoma. So when you ask this, the patient tells you, yes, doctor, I've been diagnosed with depression. In any case, not in only this case, whenever a patient is telling you that he has been diagnosed with something and he is using some medication, always try to see if his present symptoms are due to that medication. All right. So this is just a clue. If you look at many other questions in the GMC, and in the real situations as well, the patient is using some medications and his current symptoms can be due to those medications. So when you come to meftosa, he tells you he has depression. Okay, so are you taking any medications for that? Yes, doctor, amitriptyline. All right. The problem that you have can be due to this medication as well, but you do not need to tell this at this point. You just ask him, since when have you been using amitriptyline? Are you using that regularly? Yes, doctor. All right. Do you have any allergies? Any family history of eye related issues? Always ask that, because family history of glaucoma can be there. So family history. Then you ask this patient, what does he do for a living? Did he come here driving by himself? That is so very important. This patient has a painful red eye, is unable to open his eyes. Did he come here driving by himself? Then you go on to your DESA. You can ask DESA, but do not ask about nutrition, alcohol, all of them. Maybe one or two questions if you want to, but I always suggest not to ask DESA in any emergency conditions. But there are some doctors that who really like to ask. So if you want to ask at the maximum, you can ask about smoking and alcohol. Please do not go beyond that, because this is an emergency. You need to save the vision of your patient. You just cannot afford to, just a moment. You just cannot afford to put this patient at risk. All right. So this is what you need to do, Jessa. Then you go on to eyes. Do you have an idea what could be the cause? Do you have any particular concerns? Anything like that. So once you are done with the eyes, you go on to your examination part. In the examination part, the patient can be having, when you have a look externally at the eye, as I told you in the beginning, you always need to do an internal and an external examination of the eye. When you do an external examination in this patient, in optic neuritis, there would be redness in the eye, whereas in glaucoma, there will be fixed dilated pupil. The eye will be red and there will be a fixed dilated pupil. Okay. And how is going to happen in the GMC? The patient might give you a picture. When you say that I'm going to do this examination, he might give you a picture of this. Once you've seen a picture, and once you are thinking of this to be an acute angle closure glaucoma on the basis of your examination, you are going to send this patient to the A&E. If he is already in the A&E, well and good, that is wonderful, as our case is today. But if this patient is coming to the GP, immediate referral to the A&E is very important. So you tell the patient that from the information that you've given me, so now we have come to the management part. From the information that you've given me and from the examination that I did on you, it seems that you have a condition called acute angle closure glaucoma. I'm sorry for this long term. It's a condition of the eye in which the pressure at the back of your eye is increased. The fluid is building up and the area from which it is drained is blocked. Okay, so you can tell him that the area from which the eye fluid is drained is blocked. So we need to admit you. So you come to your class in 3 hours. We need to admit you immediately. I want to involve my senior ophthalmologist. We will send for some investigations. The ophthalmologist might consider doing some special investigations for you. I will give you some painkillers. These painkillers will relieve your pain. This is your duty. If you do not give the painkillers and you started talking about timolol and pilocarpine and acetazolamide and stuff, please, those are the ones that are that's the job of your senior. You may not even name these medications. So what are you going to do? You are going to give him painkiller first of all. Once done, tell him that my senior will come, assess you again, and will give you some medication to decrease the amount of pressure that is built up at the back of your eye, and also to decrease the production of new fluid. Just say in these simple words, that's all. Do not struggle with pilocarpine, timolol in your exam. They do not remember the names and they do not want you to be telling the eye cases names and the ophthalmologist's specialty names. Okay, you need to be very clear to the patient. That is what is required from us. Once done, then you've already removed the glasses. Remember that when we talked in the history, that is the light bothering you? He said yes. So all right, I'll dim the lights. You can remove the glasses, but don't dim the lights a lot, because the more darkness is around him, the more will be his symptoms. Okay, so you just tell him, I'll dim the lights a little bit, but if you will stay in dark, it will be more painful, because in dark our eyes try to the black part of our, I mean, this is what I'm telling you, not to the patient. Okay, so we know that dilation of the pupil occurs when the patient goes in dark, and his pupil is already dilated because of the increased pressure at the back of the eye. So you want to prevent any further dilatation of the eye. Once you've told him about the medications, then you go on to give him some information. Most likely your condition can be due to the medication that you're taking, that is amitriptyline. So I would want you to review your medication with the specialist, so that he might put you on some other medication for that purpose. And the eye specialist might admit you and do some surgery to make a new channel or to drill a new hole into your eye, to let the new fluid that is forming at the back of your eye get drained. All right. So this is what you need to do. Advise him not to sit in a dark room, because this can be one of his histories as well. Avoid sitting in dark rooms, and also tell him that usually one of the concerns of the patient can be that, doctor, is this reversible? Well, I'm not sure if there has already been any damage or not, or whether it is at a reversible stage or not. So the eye specialist, my senior, who is going to come and assess you, would be in a better position to answer this question. So any patient whosoever asks you that, doctor, is it going to get better, or what treatment am I going to be given in the hospital, please do not specify any treatments in any case, because what if you tell one treatment to the patient, and when he goes to the hospital, another treatment is done? He might come and grab our collar that, doctor, you said that this is going to be done, whereas it was not done, something different was done. All right, so this is it about glaucoma. You are going to admit this patient, follow the Qasim RRR, give him the red flags that if you have any worsening of symptoms while within the hospital, please do ring this bell. One of the staff members will be with you. Do not give him any reading materials because he has eye pain. Advise him to avoid driving for a few days till his vision is completely fine, till his pain is completely gone. Okay, so no DVLA right here, but you just advise him just to be a safe doctor. All right, so that was about optic neuritis and glaucoma. These are the most commonly repeated cases these days. Cataract is also coming, but I did not add that because I thought I'll just give you an overview of the cataract. Cataract patient can come with hazy vision, okay, blurred vision, hazy vision, something like that. When you start taking a history, you do not find anything else. All the eye history is clean and clear. There's nothing else. You can get some risk factors. There are certain risk factors, like, for example, use of steroids, and then if the patient is diabetic, and old age itself. These are the risk factors for developing cataracts. So this is the third topic we are doing. Remember, we are not talking about glaucoma. We are talking about cataracts. All right. So in cataracts, once you've taken the history, you've ruled out the red flags, any pain, any discharge, any bleeding anywhere, all those questions. Once you've asked about any use of lenses and stuff, you go on to your examination. On examination, you just find that there is hazy cornea. Once you've seen that, then you go on to explain it to the patient. Tell him that he seems to be having a condition called cataract. This is a condition where the lens of the eye, which is present just in the middle of the eye, the lens of the eye becomes hazy, which can be due to your age, or it can be due to certain other conditions, right? Please do not worry. It is a treatable condition, but I would highly advise you not to drive till your treatment is completed. What is the treatment? The treatment is surgery only. There is, he might ask you that are there any medications? No, there are no medications to treat this. The only way to treat this is to replace your lens with a new lens. Okay, it's just a day surgery. It doesn't take much long. Sometimes this patient might ask you that, doctor, can both eyes be operated on the same day? So according to the NHS, yes, both eyes can be operated on the same day. But it's highly advisable that you go for it one by one. But if he wants it on the same day, that is possible. Then another question is, which many of the candidates ask, not the patient, the candidates ask, that do we need to inform the DVLA? So we do not need to inform the DVLA in this case, but we need to advise the patient not to drive. Do not inform the DVLA, but inform the patient not to drive and go for surgery as soon as possible. So Qasim Arara, you've told him about the condition that is cataract. Give him referral to the eye specialist. Involve your senior if you want to. Do all the baseline investigations today. Management is none, just the information that you have to give him. And say him that once you're done with the specialist, if you have any questions, please do come back to us at any time. I'll give you some reading materials about, or the leaflets about cataracts. Right? So this is all about eye. These three cases that we've discussed today from the eye. Let's go on to our headaches. Headaches, they are continuously being repeated, especially these two cases. So we are not going to cover one case of GCA, but subarachnoid hemorrhage as well. So I couldn't make a separate slide for that because I was short of time. But we are going to cover these two topics in detail. Okay, GCA, giant cell arteritis, and subarachnoid hemorrhage. You are FY2 working in a GP. Who the patient is, Maria, aged 65, came to the hospital with headache. Take a focused history, assess the patient, do examination, and discuss further management with the patient. Other information about the patient is none. What you must do, please talk to her and address her concerns and manage the patient. So, this is a case of headache. See, it's very, very important for us to be able to identify what is the cause of headache. Sitting in the GP, see, it's not for the sake of exam. Remember that. Once you're going to be into the system, you should be able to identify all these different cases that we are studying in for Plab 2. GCA is a red flag condition. Subarachnoid hemorrhage is a red flag condition. Both of these need immediate referral if you are in the GP. Remember, if they are coming to the hospital, well and good. But if you are in the GP and you do not know that you need to refer this patient, you will definitely fail the station in the exam. Remember that these are both red flag conditions. The patient, whenever comes with headaches, do a very good history. Believe me, on the basis of your history, you are able to identify all different causes of headaches, and most of them you are able to identify within the Socrates, the pain questions. Okay, so when the patient has come to you with pain, Maria, aged 65, came to the hospital with headache. So you start taking a history. Whenever the patient is 65, coming with a headache, if this headache is for the first time, remember this fact that a 65 years old lady is coming to you with a headache for the first time is itself a red flag. Start taking a history. I'm really sorry to hear that you have a very bad pain. Are you comfortable to talk at the moment? Yes, doctor. Can you tell me more about your headache? Doctor, it's just here on the in GCA. The patient might tell you it's just all over my right eye. All right. Any and so sorry on the side of my right eye, and any pain in your eye? She might tell you yes or no, because GCA, giant cell arteritis, will have some pain in the eye as well. So this patient is coming with headache. When you take a complete history, any pain anywhere else? Yes, on in my eye as well. Does this pain go anywhere? No, doctor. What type of pain is it? It's dull aching pain. Anything that makes it better? Anything that makes it worse? No, no, no. Okay. So the location of the pain, what type of pain is it? It's a pulsating pain that I have on the right side of my head. So the pulsating pain is giving you a clue to giant cell arteritis. For example, okay, let's finish this giant cell arteritis, then we'll come to the next causes of headaches. Once you've done with the Socrates history, you ask her, apart from this headache, do you have any other symptoms, like what? Like any blurring of vision, any nausea, vomiting, any rash on any part of the body? So you are ruling out your red flags now. Have you had any trauma to the eye? Yes or no? You start taking your Socrates, your Meftosa history. Have you been diagnosed with any medical conditions, any medications, allergies? Ask all those questions. Whenever you are thinking of giant cell arthritis, you know that giant cell arthritis is related to polymyalgia rheumatica. Do ask her in the history if she has any problem climbing stairs or combing hair, if she has any problem standing up from a sitting position, because these are the actions which would be compromised in polymyalgia rheumatica. So you ask that history, you go to Meftosa. Have you ever been diagnosed with any eye conditions? Have you ever been diagnosed with any joint conditions? You complete your Meftosa. Do you smoke? Do you drink alcohol? Then you go on to your examination. Now, whenever a patient is coming to you with headache, remember that there's a set of things that you can never ever miss to do an examination. You can write it down. Any case of headache, may it be a simple stress headache, may it be a migraine or GCA or subarachnoid hemorrhage, anything at all, or it's a brain tumor, you always need to do observations, because this headache can be due to high blood pressure. You always need to do a complete head examination, because this patient is coming with headache, then definitely you will palpate around the head. You are always going to do an eye examination. So tell the patient, I'll have a look at the back of your eye. And you always need to see if there is any neck stiffness and do a complete neurological examination. So what do we do in terms of examination? Thank you for coming in, Mr. X. I would just like to do an examination on you. Is that all right? Yes, doctor. So I'll check your observations, including your blood pressure, temperature, heart rate, breathing rate, and the level of oxygen in your blood. I'll also look and feel around your head to look for any tenderness in any area. And I'll also do a complete neurological examination of your head and neck area, and of the complete bodily neurological examination that you need to do. I'll also have a look at the back of your eye. Now, this much we have covered. Not to forget, this patient as a part of examination. This patient can be having some other reasons as well for the headache. So GCA is usually very clear from the beginning. So you may not ask these questions, but in under any other headache question, you need to ask about any flu, any stuffy nose, by any chance, do you have any pain on chewing? That is for GCA. So simple questions like that as well. Once you have taken a history, you've done an examination, you go on to the management. Kasim RRR. Again, repeating once, for those who joined late or who do not know what Kasim RRR is, C is for condition, A is for admission or referral, S is for senior, I is for investigations, M is for management, acute management and long-term management. RRR, first R is for always for red flags. Second R is for review, and third R is for reading material. So how am I going to put this management into Qasim RRR for a patient who has giant cell arteritis? So, Mr. X, you seem to be, Maria, you seem to be having a condition called giant cell arteritis. Do you have an idea what that is? No, doctor, that's a big term for me. I'm sorry for that. It's a condition in which there can be some swelling in the vessels on the side of your head, and this swelling can also be in the vessels that are supplying your eye. Okay, so I'm a bit concerned at the moment. This condition can lead to irreversible vision loss. So I want you to be seen by the specialist as soon as possible. So you are sending her to the specialist for admission. Tell her that I want you to send I want to send you to the emergency department. They will give you some medications there, and they will admit you, do some further investigations. You are coming to the investigations of Qasim RRR now. They'll do some investigations, including some jelly scan of the side of your head. The vascular surgeon will also see you. He might take some sample from the vessels on the side of your head, and the eye specialist will also have a look at the back of your eye. So once you tell this patient what is going to be done in the hospital, tell him also what you are going to do now. You are going to give him steroids, high dose steroids orally. Whenever a patient presents in the GP, you need to give him one dose of high dose 50 to 60 milligrams of steroids before he leaves the clinic. That is your duty of care towards his eye. You can't miss on doing that. Once he'll reach the hospital, he'll himself be shifted to IV steroids. Don't worry about that. That's the job of your senior in the hospital. So for you, in terms of pain, give him a painkiller and give him high dose steroids. In painkiller, give him brufen. Paracetamol is not going to help him. We need to reduce the inflammation around that area. So give him brufen. Uh, Investigations are ESR and CRP. This is something that can be done in the GP, but remember that whenever you need to send this patient to the hospital, serial inflammatory markers check is going to happen. So it's better just to send this patient to the hospital. So saying once again, you seem to be having a condition called giant cell arteritis. It's an emergency condition. I want to send you to the hospital as soon as possible for admission. You will be seen by my senior, the eye specialist, and the specialist who deals with the vessels. Okay, the vascular surgeon basically. They might consider doing some investigations, including a jelly scan on the side of your head, including some blood tests, taking a sample from the artery or from the vessel on the side of your head. And for now, I'll give you some. Now you're coming to M, the M part of the Qasim. I'll give you some painkiller, give you a tablet, a steroid tablet, just to reduce the swelling in the side of your head. And while being transferred to the hospital, if you feel that you have worsening of symptoms or anything like that, please go and inform the specialist in the emergency immediately that your some symptoms are getting worse, or your pain is getting worse, or your vision is deteriorating. So this is how you give red flags to the patients. Once you're discharged from the hospital, I would like to review you and talk about the medications that you will be given by the specialist. You do not need to give him any reading material in this case because he has eye pain. You do not want him to put any stress or strain on his vision or on his eyes. Okay, so this is about giant cell arteritis. Coming on next, subarachnoid hemorrhage. So this is our fifth or sixth case for today. Subarachnoid hemorrhage. Lady, usually a young patient. It can present at any age, but just to differentiate between the two, just not to confuse the candidates. It is being given at a younger age, usually around 40, 39, 40, something like that. When you get a patient, female, male, any gender, if a patient is coming to you with a severe headache, you go in, greet your patient, introduce yourself. How may I help you, doctor? I have a very severe headache. All right, I'm really sorry to hear about that. Are you comfortable to talk at the moment? Yes, doctor, that's fine. Can you tell me where is the headache? It's at the back of my head. When did it start? 2 to 3 hours back. What type of headache is it? It's a very bad. It's the worst headache of my life. He might say so, or might say that it's a very dull, deep pain. Can have different descriptions to it. All right. So, does this ache, pain go anywhere, like towards your neck or anywhere? No, doctor. It's just there. It's very bad pain. All right. Do you have anything that makes it better? Anything that makes it worse? On a scale of 1 to 10, how would you grade it? After all that, you go on to your headache questions, as we've already discussed. Please do not ask so long list of DDs, as we did not ask in this one. So similarly, we will not ask in this one. Why? Because when this patient, GCA patient, came to us, the patient told us that he has pulsatile headache. The patient is 65 and is elderly, and this was for the first time that this patient has this type of headache, and also told you that has blurring of vision. So you are not thinking about sinusitis and ear infections and stuff like that. Okay, so whenever you come to know from the beginning that this can be something serious, leave the smaller things, leave them to one side. Similarly, subarachnoid hemorrhage, when the patient is telling you the pain is at the back of my eye, is the worst pain of my life, start taking further history. Have you had any pain in your neck? Any rashes? Any fevers? Have you had any trauma to your head? Okay. You ask those questions. Any nausea, vomiting associated with it? Any blurring of vision? Once you've asked that, you go on to your family history. Not family history, sorry, meftosa. Have you ever been diagnosed with any kidney related issues? You are thinking of perianeurysms. Have you ever been diagnosed with any other medical conditions, any allergies? Are you taking any medications? You ask all those questions. Along with that, you can also ask if he has any bleeding disorders or something like that. Usually bleeding disorders do not present with a subarachnoid hemorrhage, but yes, because it's a bleeding inside the brain, you can ask that as a question. Or if the patient is using any blood thinning medications. Once done with your meftosa, please, again, in any emergency situations, I highly advise, and this is what I followed in my exam as well, I do not think any patient who is in severe pain would be comfortable to answer you that, yes, doctor, I have been smoking for the past 20 years. That looks weird. That looks odd. Please do not ask these questions. It's not a good thing. Okay, once done with your history, you go on to your ask him ideas, concerns, expectations. No, doctor, I have no idea at all. Do you have any particular concerns? No, doctor, I don't have any concerns as well. I just want you to give me something to relieve my headache. All right. You go on to examination. Examination is the same as we've discussed earlier in the GCA case. I would like to check your observations, including your blood pressure, temperature, heart rate, breathing rate, and the level of oxygen in your blood. Then I would like to just look and feel around your head. I would like to have a look at the back of your eyes. I'll do a complete neurological examination for you. I'll also do a neck examination for you. Once you've done the examination, in subarachnoid hemorrhage, what can be the findings? There can be some increased pressure inside the eye because of the increased pressure inside the brain. So edema can be seen. Once you've done that, the patient may not give you any findings when you come to this because it's a clear-cut case of subarachnoid hemorrhage, and the findings of the fundoscopy have never been given in subarachnoid hemorrhage. You just go on to the management. Jessica, thank you very much for coming in today. From the information that you've given me and the examination that I did on you, it seems that you have a condition called subarachnoid hemorrhage. Do you have an idea what that is? No, doctor. Always keep your managements interactive as much as you can. No, doctor, I don't have an idea what it is. All right, it's a condition in which there is bleeding inside the brain, not outside the brain, okay? Inside the brain. This is what I'm telling you guys. A different stance from everyone coming. So it's bleeding inside the brain. For this, I want you to be admitted immediately in the A&E. So I want to send you to the hospital. Well, this comes in the hospital. This doesn't come in the GP. So you can tell her that I want to admit you immediately, involve my senior, do some investigations like the scans of your brain, and if needed, we might also take some fluid from the back of your spine. Okay, from your back, from your spine. Okay, so once you've told her this much, tell her that now I'll give you some painkillers since you have very bad pain. I'll switch off the lights for you since the light is bothering you. In the meantime, if you feel that your symptoms are getting worse, now you have admitted the patient. In the meantime, if you feel that your symptoms are getting worse, if you have any nausea, vomiting, or you have any other new symptoms developing, please ring this bell. One of the staff members will be with you. This much is more than enough for this case. You do not need to give her any leaflets because she has vision issue at the moment. You do not want to talk about review as well because she's in so extreme pain that you do not want to talk about that, right? Do you have any concerns? No, doctor. Do you want me to call someone for you? Did you come here driving by yourself? Just the same questions which we had for the previous case. Any problem with the vision? Ask if the patient came here driving by herself. Because if the patient came here driving by herself to the GP, she might want to go to the hospital through her same car. Okay, so you do not want that to happen. This is about GCA and subarachnoid hemorrhage. Oh, good. We are done with about 5, 6 cases for today. All right. So yesterday I received a few messages that if we can have a break in between. So I am okay with that. If you guys want, we can have a 5 minutes break and then get back to our ear cases. How does that sound to all of you? I think it will sound good to everyone. So I'll just mute myself. Will unmute myself after exactly 5 minutes from now. Just take some glass of water. If you have any questions, you may write them down. We'll just have a break for 5 minutes. Okay? And then we'll start our ear cases. We are going to target more and more so that we can finish more than 100 cases in these 10 days. All right? Okay. All right. Hello, yes, I'm back. Um, I hope everyone is back here too, since it has already been 5 minutes. Let's start with the eye cases. In the eye cases, we're starting with cholesteatoma. Before we start, I'll just give you a structure of the history that you need to follow. Please always remember it's not a detailed structure, and so just an overview of what should not be missed, right? So, whenever a patient is coming to you with an ear problem, which can be ear pain, it can be ear discharge, it can be anything. So, whenever a patient is coming to you, or it can be any difficulty in hearing, it can be tinnitus, it can be fullness in the ear. So, you think of these 4 or 5 things and remember that these need to be asked in any question. A patient who is coming to you with ear pain, ask him the pain questions, all your Socrates questions. Once done with the pain questions, you ask him anything else apart from the pain. Yes or no, doctor. After that, you go on to take your differentials history. What are the differentials? Again, just like the eye, remember that anything going into the ear or anything coming out of the ear. What can go into the ear? Well, there can be some air, so you need to take a history of flying. There can be some water, so you need to take a history of swimming. It can be a foreign body, so ask him if he has been using any cotton buds to clean his ears. Things coming out, remember it can be some blood, wax, discharge. 3 things, right? So now easy to remember what you need to ask in the ear history. 3 things that can go in, 3 things that can go that can come out, and then definitely some other symptoms. Remember 3 other symptoms. So 3 things that can go in, 3 things that can come out, and 3 other symptoms. What are the 3 other symptoms? Have you had any fullness in your ears? Have you had any ringing? Have you been hearing any ringing sounds and any difficulty in hearing? All right. So now your almost your ear history completes over these questions. Then you do ask about some red flag situations like apart from this ear pain, have you had any trauma? Any patient who is coming to you with a trauma and ear pain or hearing problem is a red flag. Remember that there can be a damage to the nerve because of damage to the bone. So remember to ask about trauma. Then you've taken the remaining history, and then you go on to ask about maftosa history. Effect on life is very very important when it comes to hearing issues because usually they can be chronic. Ask him, is it for the first time or have you been having this problem in the past as well? This is a very, very important question because usually in chronic suppurative otitis media, which is not a case today, but telling you otherwise, that in CSOM and in cholesteatoma, in problems like this one, the patient can have a long history of having ear-related issues. So when you are asking about taking the ear history, do ask that is it for the first time? If he has had any trauma, go to your maftosa, complete your maftosa. Family history is very important. Always complete with your maftosa. Anybody else who at home has been having same problem, in cases of ear discharge and acute otitis media, contact history can also be very very important. Remember that. So this is an overall structure of the history that I'm giving you. If it's a child, always remember to ask if anybody is smoking at home or if the child is immunized or not. So those are risk factors for small children. If the baby is bottle feeding, so those are some of the risk factors for small children. Okay, so this is the overall structure. Coming to our case now, cholesteatoma, you are FY2 working in the GP, 50 years old male, consulting for an ear problem. Other information about the problem, this is your first time seeing the patient. So nothing much. What you must do, talk to the patient, take history, perform relevant examinations, and discuss the plan of management. So actually, it is an examination station. So now, because examination stations, especially the ear ones, they are a big fear factor for many of us. I'll tell you how to deal with these examination stations. So try to focus on what I'm trying to tell you now. This male who has a cholesteatoma can present either with ear pain, ear fullness, or hearing issues, or discharge from the ear. So there can be 2-3 different types of presentations in terms of cholesteatoma, or all of these symptoms can be present together. So you start taking your history, pain history, 3 things that can go in, 3 things that can come out. The other symptoms that we've already talked about, any trauma, any hearing issues, any tinnitus, any fullness in the ear, you go on to your meftosa. Once done with the meftosa, you ask the patient about eyes, meftosa, DESA, done all those things. And is it for the first time? You've already asked this patient. He might tell you that, doctor, I have been having recurrent ear problems, recurrent ear infections in the past. This can be a very important history for you. Okay, this patient might be having some discharge from the ear. This patient can be having pain. We can't make a diagnosis on the basis of this information. So we need to examine the patient. The diagnosis cannot be made without examination. So you thank the patient, you go on to your next step, that is examination. So you do your complete observations. Thank you, Mr. X, for all this information that you've given me. I would like to do an examination on you. Please do remember that just like headache case, just like eye cases, we need to do certain steps in ear examination which should not be missed. They can have some clues. What are the exact steps? You check the observations of the patient. Tell him that I'm going to have a look around your eye, ear. I'm going to have a look around your ear, feel around your ear. With your hands, you're going to feel around. I'll also feel for some glands in your neck and in front and at the back of your ear. Then you go on to, you're still on inspection and palpation, right? So now you want to look inside the ear. You are going to use otoscopy to look inside the ear. Once you've looked inside the ear, I won't be able to tell you the technique and stuff. You can focus on that yourselves because we are not doing an examination station. I'm just giving you an overview of how you're going to deal with cholesteatoma. There are certain steps for the examination as well. Like, for example, using your right hand, holding the otoscope with your right hand like a pen, looking into the patient's right ear with your right eye. So 3 R's would be there: your right hand, patient's right ear, and your right eye to look inside. Similarly, on the left side, it will be your left hand holding like a pen, patient's left ear, and your left eye. Okay, so just remember the sequence. Can't go into further details of this. You do the otoscopy and then always do the tuning fork tests. This is something many candidates forget when they see that, oh, okay, I have to, they see an otoscope, they forget about the tuning fork tests because on the exam table, there won't be any tuning fork because they do not want you to come near the patient to do the tuning fork tests. So performing the tuning fork tests is not required in the exam, but verbalizing that I would like to do some special tests, tuning fork tests on your ear is very, very important, because if you want, you will not say that, the examiner will not give you the findings as well. Okay, the findings of the hearing tests. All right. So what you can see inside. This is what you can see inside in terms of cholesteatoma. There's a white cheesy material on the upper posterior part of the ear. Okay, just like this one. Always focus on white cheesy material. Whenever you see that, you are thinking of cholesteatoma. This patient has been having some pain, discharge, hearing issue from his one ear, and he has been having a history of recurrent ear problems as well. When you examined him, you found that there is a white cheesy material on the upper part of his ear. You come to the management. What's the management? Qasim RRR. Thank you, Mr. X, for coming in today. From the information that you gave me and the examination that I did on you, it seems that you have a condition called cholesteatoma. Have you ever heard about that? No, doctor. It's a condition where there is collection of dead cells, non-cancerous dead cells in your ear, in the middle part of your ear. Okay. It is not a cancerous condition. So you can say that it's a non-cancerous condition where there is a collection of dead skin cells in the upper part, in the middle part of your ear. Once you've told him about the condition, tell him that for this, I want to refer you to the specialist. You need to give an urgent referral, that is a 2 weeks referral, or even routine referral can be given for this one. Okay, remember that when do we need to give an immediate referral in cases of cholesteatoma? I did not say a few signs before because I wanted to say them at this time so that you can remember. What are the situations when you need to give an immediate referral just now, immediately sending him to the hospital? If the patient has any neurological disturbance, if he says that he has headaches associated with this ear pain, he has blurring of vision as well, and if you find any neurological deficit, it means that this cholesteatoma has already started invading the brain and the skull. And this is when you want to give an immediate referral to the ear, nose, and throat specialist. Remember that whenever you're taking the eye history, you can ask a few questions about the ear. Whenever you're taking a ear history, you have to, not you can, but you have to rule out the red flags, which include trauma, which include blurring of vision, headaches, and neurological deficit. So whenever it comes to hearing problem or ear problems, uh, do ask about headaches and blurring of vision and weakness in a part of the body as well. If there is any one of these signs present, please send this patient to the hospital. Always send this patient to the hospital immediately. You can't wait even a single minute. Once you've sent it, then it's the job of the specialist. In your GMC exam, usually up till now, I have not seen that they are giving this as an emergency condition. So if it is coming as a non-emergency condition in which there are no such red flags present, you can tell the patient you seem to be having a condition called cholesteatoma, which means this, which I've already told you. For this, I want to refer you to the ear, nose, and throat specialist within 2 to 4 weeks time. Uh, in the meantime, I can run some investigations just to make sure that your bloods are fine. And if you have any worsening of the symptoms, if he has pain, give him the painkiller. If he has discharge as a symptom, depending on whatever symptom he has, give him treatment, give him management. If he has pain, give him a painkiller. If he has discharge, ask him to use tissue spears to clean the discharge and not to use cotton buds. All right? Ask him to avoid swimming for some time. If he has very severe ear pain, give him some painkillers. This is what you're going to do in the management part. Then you give him the red flags. If you're giving him a routine referral of 2 to 4 weeks, give him some red flags. If you feel that there are any headaches that are worsening, any blurring of vision, any weakness in a part of the body, please do come back to us early. We might have to send you to the specialist on the same day. Then you tell him that you can review him once he's discharged from the specialist. Sorry, what was the management? I completely skipped or missed saying the management part. The ultimate management. Once you have given him, the management is divided into two parts in the Qasim RRR. Immediate management would be giving him painkillers, giving him tissue spears, asking him to avoid certain activities, and at the same time tell him that once he's at the hospital, surgery is the only treatment for this. Doctor, can I mean, postpone the surgery since it's a non-cancerous condition? Can I please delay the surgery? I do not want to have a surgery. I'm afraid of the surgery. The patient might say anything. It's our duty of care towards the patient who is coming to us in the general practice to make sure that he goes to the ENT. Why? You need to be able to convince him that I understand, Mr. X. You do not want to have a surgery, and it is a non-cancerous condition, but still this non-cancerous condition can sometimes go into the brain. It can just multiply and it can invade the brain. We do not want anything like that to be happening for you. Please, you need to go to the specialist. So convince him, counsel him, send him to the specialist. Give him some reading material as well about the situation. You've done the tuning fork tests as well in the examination part. There would be some sort of conductive deafness in this case. As a finding, just remember that there would be some conductive deafness. I wish I could teach you ear in a more better way because I really love this topic, but do not have much time because of that. We'll just go on to our next topic. But I hope I covered the important points, the important tips that you can use in terms of taking history. 3 things coming out, 3 things going in, other 3 to 4 things, and then going to your maftosa and going to your examination. What you shouldn't be missing on examination is the tuning fork tests. When you do that, in this case, you can get conductive deafness. In any case, when you get this type of presentation, weakness in one part of the body or something like that, you're getting sensory neural deafness, think of acoustic neuroma. Okay, that's a different topic. So let's just leave that for now. Go to our big topic. That's BPPV, vestibular neuritis. Okay, we might skip on unilateral tinnitus for today because we are already short of time. We'll try to cover these 2 topics for today because I think we'll have covered maybe how many topics, just to make sure that 1, 2, 3, 4, 5, 6, 7. Okay, we'll cover 7. All right, so coming to BPPV. BPPV, whenever a patient is coming to you with dizziness, remember that. It's a wide topic. You may not be able to gather the data that I'm going to give you now from a single resource. It might take you a lot of time to gather this data, so please listen carefully. Whenever a patient is coming to you with dizziness, always ask your first question. May I know what do you mean by dizziness? Doctor, I feel that the room is spinning around me or the environment is spinning around me. All right, now you have come to know, because dizziness is it's an umbrella term that can be used by the patients for vertigo, that can be used by the patients for lightheadedness, that can be used by the patients sometimes when they feel like they are going to faint. So it's an umbrella term. You need to clarify what exactly the patient means. When you ask the patient, if the patient says that, doctor, I feel that the room is spinning around me, okay? It means that this patient has vertigo. If he says that I feel lightheaded, this is not vertigo. Then your differentials change. Then you need to go on to the differentials of cardiac causes. Then you need to go on to the differentials of the causes like any neurological issues and any vasovagal syncope and stuff like that, okay? But here, when the patient says that, doctor, the room is spinning around me, always think of vertigo. In BPPV and in vestibular neuritis, both these conditions, and in Meniere's disease as well, the patient has vertigo. All right. Once you have established that this is vertigo, you go on to your next questions. When did it start? Is it for the first time? Did it start suddenly? Is it continuously happening like that? Does it come and go? Once he says that, doctor, it comes and goes, ask him, how long does it last each time? This is the most important question after asking the initial history. Why? This duration is going to give you an idea that what it is. Any episode that lasts less than 1 minute, if the patient says that it lasts for a few seconds, remember that it is nothing else but BPPV, benign paroxysmal positional vertigo. If the patient says that it lasts for minutes to hours, it is nothing else but Meniere's disease. Okay, so lasting for seconds is BPPV, lasting for minutes to hours is Meniere's disease, and lasting from hours to days is your vestibular neuritis. All right, I hope this is very clear. Please put this into your minds. I have seen many candidates performing in a way that they mix between BPPV and vestibular neuritis. All right, the patient who is coming to you with flu-like illness is usually a case of vestibular neuritis, not BPPV. Okay. Okay, going on to your remaining history. when you found that this patient has dizziness and you've taken the initial history, you go on to ask this patient about some other conditions, because dizziness can be related to 4 different areas of the body. It can be due to your head, it can be due to your ears, it can be due to your cervical cervical issue, I mean the neck issue, and then it can be due to your heart if anybody has any arrhythmia. So now I'm going to say the whole history that you need to take in this case. Hello, Mr. X. I'm Dr. XYZ, one of the doctors working in this practice. Can you please confirm your name and age? How may I help you? Doctor, I have dizziness. All right. Can you tell me more about this dizziness? What do you mean by dizziness? I feel like the room is spinning around me. I'm really sorry to hear about that. Since when has that been happening? It has been happening for the past one day. Is it continuous or does it come and go? It comes and goes, doctor. For how long does it last? It lasts for a few seconds. All right. And anything that makes it worse, doctor, whenever I turn my head to one side, or whenever I'm turning myself inside the bed, taking a turn to one side, I always feel the same. Okay. Anything that makes it better, doctor, whenever I still my head, I stop moving my head, I feel better. All right. Apart from this dizziness, have you had any other symptoms? Like what, doctor? Any ear pain, any ear discharge, any ringing in the ears? No, doctor. Oh, yes, doctor. He might say anything, but in BPPV, there will not be anything else. Then you ask him about head signs. As I told you, 4 areas. Ear, you have asked, have you had any headaches or blurring of vision? No, doctor. Have you had any pain in your neck? No, doctor. Any fast racing of the heart or shortness of breath? No, doctor. See how beautifully you have covered 4 areas for ruling out differentials of your dizziness case, because you want to be a safe doctor, so you do not want to miss on anything that is important. Once done with your history, you are already sure up till now that this is PPPB on the basis of your initial history. You have also ruled out your red flags of your cardiac causes and your brain causes. Then you go on to your quick nephrosa. Then you go on to your eyes. Do you have an idea what could be the cause? I have no idea at all, doctor. All right, I would like to do a quick examination on you. Would that be all right? Yes, doctor. On the basis of your initial history, when you already come to know that this looks like BPPV, please remember that you have to add in Dix-Hallpike maneuver in your examination part. So starting with our examination of the ear, as we always do, because this is PPPV, this patient might be having some balance issues, because this patient has spinning of the head and stuff like that. So you have to do a little more extensive examination. You don't have to do it practically, so you just have to verbalize. So don't forget to verbalize that. I would like to check your observations, including your blood pressure, temperature, heart rate, breathing rate, and the level of oxygen in your blood. Then I would like to do an ear examination on you, a complete neurological examination on you. I'll also listen to your heart and do just ask you to move your neck around. So you have done the examination for your initial causes of dizziness, and I would also like to do a special test for you called as Dix-Hallpike maneuver. You need to say this in order to get the result, otherwise you will not get the result. Once you come to know that the Dix-Hallpike maneuver is positive, you know that you have confirmed your BPPV. Now you tell the patient, thanks for coming in today. You seem to be having a condition called BPPV on the basis of your history and examination. For this, this is a self-limiting condition which usually gets better by itself, but there are certain things that we can do for you. Okay. So there is, just like I did a maneuver to diagnose it, there is another maneuver that can be done, which is called as the Apple's maneuver to get relief of symptoms. Oh, okay, sorry. In BPPV, how are you going to explain the condition? I forgot to tell you that. So you explain the condition to the patient. So this PPPV, you have this vertigo because the inner part of the ear is responsible for keeping a good balance. Okay, so sometimes a small calcium deposit, it moves into the fluid of the inner ear. That is when we get this type of symptoms. All right, so first tell him that the inner part of your ear is responsible for keeping your balance and stuff. whenever there is this happens, so you told him that small calcium deposit, it sometimes break from the side wall and it moves inside and cause these symptoms. Now the Apples maneuver, I can get help from my senior in the practice who can do this maneuver on you, the Apples maneuver. This maneuver, when done once or twice, it can help remove this deposit from the inside of your ear and get a relief of symptoms for you. How does that sound to you? Yes, doctor, I'm fine. I just want to have that done because I'm really worried about this vertigo. Okay. Apart from that, advise that because once performed, he may not get a relief. You may not need to perform the Apples maneuver 2 to 3 times. Tell him that, please ask him if he drove to the clinic by himself, ask him please do not drive back home, better call someone to pick you up from here. This is actually what they are looking for, that are you a safe doctor or not, are you sending all the eye pain cases and the and the vertigo cases or the dizziness cases back home driving or not. Okay, so this is a part of our consultation. We always need to be a safe doctor. We always need to make sure that when this patient is going back home, he is safe to drive. He's safe for others who are on the road. So just address his driving. If he asks for any treatment, tell him that usually there is no treatment for this. Any type of treatment is not going to help you. It's a self-limiting condition. Try to make sure that when you get out of your bed, be a little bit careful because your head will move and you will have the symptoms. So try to minimize your head movement. Whenever you are in a standing position, try to hold on to something so that you may not have a fall. That's it. That's all about BPPV. All right. In this BPPV scenario, sorry, you would have also asked this patient about flu-like illness. All right. So when you ask this patient about flu-like illness, you are ruling out if this patient has vestibular neuritis or acute labyrinthitis. I think I should put it here. Slash acute labyrinthitis. Okay, why did I put it here? Because both these conditions are almost the same, except for one difference, one or two differences. Okay, so we've already done our previous case, finished that. I hope everything is clear. If there will be any questions, they'll be taken at the end. Coming to the vestibular neuritis and acute labyrinthitis. The patient came to you with the same complaint. Doctor, I have dizziness. The same. I've copy pasted the same question here to let you know that there is no difference in the presentation. Okay, that was also Jessica, dizziness 27, same patient. Okay, so the patient has come to you with the same complaints. Now you started taking your history. What do you mean by dizziness? Is it for the first time? When did it start? Then you took your remaining history. How long does it last? Blah blah blah. All we have already talked about the history. We do not need to waste time on that. Once you have taken a complete history, you've also asked this patient that if she had a flu-like illness in the recent past, she will say yes. She might say yes, or she usually yes for the exam situation. She will definitely say yes. Okay. And the duration of the symptoms would not be seconds, which was the case in BPPV. Here in vestibular neuritis, the duration of symptoms would be minutes to days. We have already talked about that. I'll say it once again. Symptoms, episodes lasting for seconds. That is your BPPV. Symptoms lasting for minutes to hours is your Meniere's disease, and symptoms lasting from hours to days is your vestibular neuritis or acute labyrinthitis. What are the symptoms that can be present in both of them? The patient can have very severe vertigo, will also have problem with balance because this vertigo is lasting for hours and days. This patient is unable to stand. Whenever stands, feels like falling to one side. The patient will have some nausea and vomiting. In both these cases, I'm talking about both of them. The patient will have some nausea and vomiting. The patient can have, very rarely, can have tinnitus as well. In vestibular neuritis, the patient will not have any hearing loss, whereas in acute labyrinthitis, the labyrinths are affected, the patient will have hearing loss. In both these situations, all the symptoms are going to be the same. Since we are just talking about vestibular neuritis, so now for the sake of our session today, I'll again remove this acute labyrinthitis from here. Just have a look at this vestibular neuritis now. Vestibular neuritis, you have diagnosed that most likely this looks like vestibular neuritis. You came to your examination. On examination, you are going to do the same examination as you did previously. You check for observations, you do an ear examination, you do a head examination, neck examination, and chest examination. Also check for balance, okay? You can ask him to stand, you can do Romberg's test, because you know, there's something very, very important about vestibular neuritis. The type of symptoms, the type of continuous symptoms lasting from hours to days, when they are present, we are too much afraid of missing on something related to the brain. We are too much afraid because see, when the symptoms are lasting for seconds, we know we do not expect that the symptoms which are lasting for seconds and then getting back to normal by itself, and then they are only related to head movement, we are not expecting them to be related to brain. But the symptoms which are continuously there, lasting from days to hours, from hours to days, and the patient has this bad vomiting as well, which was not present in BPPV case. The patient is unable to get up from the bed, can sometimes have a little bit of headache as well, and tinnitus as well. We always want to rule out something sinister, something serious, like a brain-related issue, like a brain tumor. So, in our examination, coming back to our examination, you will do your observations, you will do an ear examination, you will do a head examination, a neck examination, a chest examination, and then you will do a head impulse test. Head impulse test, I do not want to go into the details, just remember the name. If you say that, your examiner is going to be too happy with you, because head impulse test is the test that is done to differentiate between vestibular neuritis and some central causes of dizziness. Okay, head impulse test is the test that you, so any patient who is coming to you with vestibular neuritis, despite the fact that he or she has given you a history that they've had a flu-like illness in the past, and does not have any specific symptoms of a brain tumor, if you do a head impulse test in this patient, your examiner is really going to know that you have a deep understanding of the topic. Okay, so do a head impulse test. In cases of vestibular neuritis, the head impulse test is positive. In cases of brain-related issues, the head impulse test is negative. So now this is also important for you to remember that if they say that the head impulse test is negative, it means that it is nothing related to brain. This dizziness is not related to brain, okay? If the head impulse test is positive, it means that it is related to ear. It is not related to brain, right? So head impulse test positive, it is related to ear, it is due to vestibular neuritis. Then you go on to your management part. Management is relatively simple, nothing much. You can give this one as well. There is no specific management in which you can give the management to the patient and then his symptoms will regress and will become completely normal. You just need to give some self-help tips like we did in the previous cases. So you start with your Qasim RRR. You seem to be having a condition called vestibular neuritis. Do you have an idea what that is? No, doctor? It's a condition where there is swelling around your inner part of the ear, the nerve of the ear. Once you've told him, it can be due to the flu-like illness that you had recently. Okay, please do not worry. It's a self-limiting condition, but it's very important for you to follow certain tips. Like, for example, in order to avoid having a fall, he can take the help of the wall while walking, or use a stand for that, and try to take maximum rest. Just simple stuff like that. Ask him to be careful while walking so that he may not get dizzy and have a fall and have a head trauma. So you are asking him to be careful moving. Please do not drive. It's very dangerous for you and for the people around. For the sake of medication, okay, you can do some routine blood tests for him if you want to, although they are not needed. But if you want to follow the CASM-RRR, you all do all these things. You involve your senior in order to confirm your diagnosis. You send for some baseline investigations. You do the management. In the management, you are going to give this patient some anti-sickness medication. You can give this patient some medication for vertigo, like beta histine. If this patient has a lot of trouble, sometimes, very rarely, you can also give them some benzodiazepines. This is all what you can do. Depending on the symptoms that the patient has, you just need to treat them according to that. Okay, not much to do in terms of the exact treatment or management. So just a symptomatic sort of treatment. Then you send the patient home back home with the red flags, the reading materials, and asking him to review you in maybe some time. If he has any worsening of symptoms, he can come early. What can be the red flags? Headaches, any blurring of vision, any neurological deficits. Those are the red flags in this case. All right. So that's all what we have for today. We have covered enough, I think so. Um, about 7 to 8 topics for today. So, any questions? I will just take a minute and then open it for question answers.